House of cards obviously is a very fragile structure, cards built upon each other and very vulnerable, yet is an edifice. And I think that's a fair analogy to the role that the DSM has played throughout its iterations, starting with DSM-1, where each iteration is viewed as the dogma or the concrete diagnostic reality of psychiatric disorders, rather than as an approximate tool to allow conversation to occur between people, to have a language that they share, to discuss patients, discuss diagnoses, and to help the field evolve.
Welcome to Health Beat, a medical news podcast series from MJH Life Sciences. I'm your host, Kevin Kunzmann. Today we're going to be discussing the American Psychiatric Association's proposed changes to the DSM guidelines for diagnosing psychiatric conditions and disorders. I'm going to be joined by Assistant Managing Editor Leah Kuntz from Psychiatric Times, and we're going to be hearing from experts including Psychiatric Times Editor-in-Chief John J. Miller. Let's dive in. For 13 years, psychiatrists have relied on the fifth edition of the Diagnostic and Statistical Manual of Mental Disorders, better known as the DSM-5, as a central framework for diagnosing and classifying mental illness. But the field of psychiatry has evolved significantly since the publication of DSM-5 in 2013, with advances in neuroscience, growing debate over diagnostic boundaries, and increasing scrutiny over how psychiatric diagnoses shape research, drug development, and access to treatment. Earlier this year, the American Psychiatric Association outlined its roadmap for a new DSM, including a major structural change, transforming the manual into a living document, designed and updated more dynamically as scientific understanding evolves in the field. For clinicians and researchers alike, the shift could reshape how psychiatric conditions are defined, studied, and treated in the years ahead. I'm joined now by my colleague Leah, who has been covering this topic for Psychiatric Times for more than 5 years now. Leah, how are you doing today?
I'm good. Thank you so much for having me.
So let's just start with, big headline topic. Is it fair to say that the proposed changes to the DSM would be the biggest in concept since the DSM-3 standardized psychiatric diagnoses years ago?
Absolutely. This guidance, which has come in a series of 5 articles from the American Journal of Psychiatry, provided by the APA Future DSM Strategic Committee, is, in essence, as you said, a roadmap to updating the DSM. The DSM, up until this point, has provided a common language for psychiatrists and mental health clinicians, and in that regard, it's been enormous. It is the psychiatric Bible, as they like to say. But many clinicians believe its categorical structure doesn't really reflect clinical reality, that it falls short of recognizing the many factors that come into play when making a mental health diagnosis. It's also a huge change in name. We don't actually know if it's going to be called DSM-6 following DSM-5, as they've adopted a new moniker. It's now, rather than the Diagnostic and Statistical Manual of Mental Disorders, it will be the Diagnostic and Scientific Manual. No one's provided any context yet on whether that will mean a shift to a new DSM-1 or if it will just follow with DSM-6. We'll have to stay tuned on that. But back when DSM-3 came out, there were some conflicting ideas about the mechanisms of mental illness. As I understand it, there wasn't a lot of empirical data, and there were a lot of differing opinions. And the DSM of that era reflects that. But a new era is beginning.
It seems so, yeah. Stay tuned for exactly what we want to call it, because that'll certainly help as a big proponent of medical acronyms. But I guess the bigger question is, why are we doing this now? I mean, obviously, we're working with, to your point, a 12, 13-year-old document that has had some, fair criticisms from the field. What's the importance of the timing of right now in 2026 to pursue this living form of the DSM?
Old editions quickly become outdated due to long intervals between publication. And I think this time around, they don't want it to seem like they're just publishing another textbook as like a cash grab, if you will. This committee believes now is the time to move toward a DSM that acknowledges and addresses the interplay of factors in mental health diagnoses. We're talking neurophysiological, developmental, experiential, sociocultural, environmental, and biological factors, all of it. Having an online document, too, that is continuously evolving as new data is released means psychiatry won't have to wait for that periodic update. This directly impacts, in my mind, things like psychopharmacology, insurance coverage, and ultimately patient outcomes.
And obviously that segues nicely into the question of like who's really driving the force behind this. As we're alluding to, clinicians are really striving for this, but is it also a regulatory priority? Are patient groups very invested in this? Whose brainchild would we really attribute this to?
This has definitely been a project of the APA for some time now. They've always provided the DSM and its updates. The future DSM Strategic Committee started with this particular project in May 2024, I believe. And I think the impetus has been feedback from practicing clinicians. It's experienced a lot of criticism. We've heard a lot on that front. But obviously, this change is going to have a huge widespread impact to reflect the psychiatry of 2026.
Let's get into some of the expert insights that we've been accumulating on Psychiatric Times since this news came out, and really prior to it as well. I know you very recently spoke with some experts about whether the DSM was helping or hindering current psychiatric patient care, as we're alluding to. What were some of the biggest critiques that were levied on DSM-5?
I think the first thing we can address is the global impact. DSM is a uniquely American manual. As I understand it, the rest of the world adheres to the International Classification of Diseases, the ICD. Dr. John Miller, our editor-in-chief, has suggested that perhaps the time has come to work with the World Health Organization to integrate or transition DSM into the next iteration of ICD, which would be ICD-12. I think conglomerating our ideas of mental health should be a global idea, not just, keeping ourselves isolated as Americans with the DSM. If we can have that common language across cultures, I think would be huge, both in diagnosing, but also defeating stigma, which I think is a huge, huge part of it. Another criticism that stood out to me is the complaint about thresholds, which I thought was so interesting. Awais Aftab, who is our March cover author and board member, pointed out that the DSM thresholds do not clearly optimize diagnosis, and some thresholds even seem semi-arbitrary by design. For example, depression diagnosis. You have 5 criteria for depression that were chosen as a threshold because, quotably, 4 seemed like not enough and 6 seemed like too much. There's also prolonged grief disorder. You have to experience it for 12 months to qualify for a prolonged grief diagnosis, but in my mind, is 11 months not also a prolonged period of grief? I would say so. And then I also recently spoke with Dr. Molly Perlman, who is the chief medical officer at Monte Nido, which is an eating disorder care organization. And she shared with me that there are proposed updates to the definitions and severity of eating disorders. Weight is often used as a determinant of severity for eating disorders, but they're working now to remove that. Eating disorders are currently judged based on BMI. And as Dr. Perlman explained to me, this is weight bias. Weight is not a behavior, and it is not immediately indicative of an eating disorder.
Historically, the image of someone with an eating disorder has been termed swag, a skinny, white, affluent girl. We know that stereotype has long been debunked. More recent data shows even more than a third of those with eating disorders identify as male. One recent statistic showed that only 6% of folks with eating disorders are actually underweight. At medical school and in training, we're all taught to you can identify someone who's very malnourished, underweight, screen for anorexia nervosa. But the issue is anorexia nervosa can exist in any body size. Restricting can be extremely harmful in the way that people are working towards weight loss as a goal, regardless of body size, if it's being done in a disordered way through excessive exercise, misuse of medications such as stimulants or GLP-1s we're seeing now. Really, and in addition, then all the isolation and the mood disorder, anxiety disorders that come along with it really lead to an increased prevalence of eating disorders. But not just that, we're seeing folks go longer and longer before getting identified.
If new specifiers focus on how functionality is affected, not how much the patient weighs, she says this will be like a huge change, not only in our concept of eating disorders, but again, it'll go back to that defeating stigma and making diagnosis easier for the practicing clinician. It's something they've been fighting for a long time. So hopefully the new DSM will focus on addressing a criticism like that, like the thresholds.
Yeah, as someone who's been privy to covering essentially every spectrum and topic and specialty in medicine, like it is fascinating, unfortunately, to hear that psychiatry is still encountering an issue of finding universalities and more refined measures and informed evidence-based, measures and gauges for conditions that are affecting millions of patients. So obviously very fair, charges laid by the folks that we've been speaking to. Another major criticism around the DSM has been the really broad, as I'm describing, or symptom-based approach to diagnostics versus a more biologically grounded approach like we have in some of these other fields. Is there any expectation that DSM-6, or whatever we want to call it, would add more dimension and context to psychiatric diagnoses?
Psychiatry, unlike some other medical fields, is not reliant upon solely biological factors. And this has been a huge argument by the anti-psychiatry movement to discredit its practice. But to answer your question, yes, the APA committees are trying to set new goals for this DSM to better incorporate biological factors and biomarkers in that regard. According to Jonathan Alpert, he's the vice chair of the future DSM Strategic Committee. The first goal is to use DSM as a way to inform the field and other stakeholders, that includes patients, groups, about promising areas of work that can inform clinical care, but may not yet be ready to be implemented directly. This could be like immune markers. I know they noted genetic markers, neurocircuitry-based measures, receptor-based measures. And the second goal is to develop a rigorous and standardized evidence-based framework to help sufficiently validate clinical care and research. These tests could help predict disorders and the course of illness. But we can't develop tools to gauge diseases we don't understand yet. I know Heidi Ann Dorr, our editorial director at Psychiatric Times, just returned from a conference in Portugal discussing stuttering as part of a psychiatric aspect, if you will. And one of the doctors was talking about how ADHD care has recently been transformed. We didn't understand ADHD yet. We always thought it was only in youth, predominantly in boys. It was going underdiagnosed in those other groups. Likewise in schizophrenia. We didn't know anything about cognition in schizophrenia yet, so we didn't know how to target it. But now we do have the psychopharmacology and the knowledge and the research to address those issues like ADHD in girls, ADHD in adults, cognitive schizophrenic issues. I think those are things now that we have the information, we can better gauge and assess. And a new DSM would really be able to capture those updates as they're happening because it's a living document. I also think psychiatry is best practiced, as I've come to understand from our thought leaders and our doctors and clinicians, through patients. I know Alan Tasman, he is a former editor-in-chief of Psychiatric Times, as well as a former APA president. He tells a story of how he worked with one particular patient with a DSM diagnosis of depression, but after a year of treating her and talking with her, their rapport and their therapeutic alliance was so strong that she finally opened up, and it turned out she really probably better fit under a diagnosis of PTSD. But his understanding changed, but it was also inhibited by the current setup of our healthcare system with 15-minute med checks. He wouldn't have understood her diagnosis and her condition with just a 15-minute brief chat with her. That isn't enough to understand her condition. And I think that's really important to remember as we go forward with this, that psychiatry isn't like some of those other medical fields where it can be summed up in a single test. It really is about the whole person care. And I think they're really trying to capture that maybe with this new DSM.
It's almost like our diagnoses are a little bit of the iceberg theory of like what more is lying underneath. Just because of what we're seeing apparent up top is not, the entire information of what's beneath. And as you're describing these misdiagnoses, which I guess like more so for interpreting it as a spectrum is it's on the right track, but it's not so refined. So exactly as you're describing the logic of an evolving field of understanding requires an evolving document at the time and not something that's static with, iterative updates as we go along. It's even more frequent than that. I think something that there's a good amount of investment from not just patient groups, but I'd certainly say from our team as well of vested interest in seeing further development and progress to help support patient groups is really around, clinical therapy development, and regulation for these patients. And because DSM diagnoses determine clinical trial eligibility for patients and therefore influences our FDA drug approval process, how do we think changes to the DSM could influence psychiatric drug development?
Yeah, as shared by our editor-in-chief, Dr. John Miller, there's a lot of rigidity to our current system. The FDA approves drugs for a set diagnosis. Patients need to have set diagnosis in order to get approval or access for a drug.
The problem is the DSM diagnoses are fluid. They're not absolute. And ultimately, as we especially saw, for example, with the serotonin selective reuptake inhibitors, a drug that is shown to be effective to treat unipolar major depression, we learn is effective in a whole range of other diagnoses, but yet often will be declined authorization by insurance companies because they say, well, the drug's not FDA approved for that. And it creates an obstacle that creates a lot of frustration and difficulty and challenges for all parties involved. And in my view, the problem is assuming that the DSM in its current iteration is the concrete measuring stick of a specific diagnosis. And if a drug is FDA approved for that diagnosis, then an insurer will pay for it. Otherwise, it can be declined. And so we have this interwoven effect of a diagnosis that is relative and that is in evolution as our understanding of the brain and psychiatric diagnoses and treatments evolve. But the FDA requiring a fixed diagnosis that's relative to get approval for a drug, and then that drug gets locked in that mold. And it's hard for us as providers to access that drug for other symptoms, other disorders that could benefit.
A diagnosis is in evolution as our understanding of the brain and neuropsychiatry and psychopharmacology evolves. And it's important that the DSM reflects that. If our understanding of the diagnoses changes, so does the eligibility and availability of psychiatric medications. So it could definitely impact the pipeline as we know it. I know Dr. Miller's March editorial talks about this. There's a drug approved by the FDA in 2014, hydroxyzine hydrochloride, for symptomatic relief of anxiety and tension associated with psychoneurosis. But psychoneurosis is no longer part of the DSM. It's not a diagnosis in there anymore. It's just residual from when those brand name products were still approved by the FDA. It doesn't exist, our understanding has changed. It's been eradicated from the DSM. I think we still need to play catch up between the psychopharmacology pipeline and our DSM understanding.
Absolutely. I think, that's very apparent. I mean, like, we can't get to a clean slate, certainly, with our armamentarium of treatments, but we need to continually refine, same as with the document. So thank you for highlighting that. Let's talk a little more practically about the living document itself for psychiatric diagnostics. How does that tool shift the work of the clinicians and caregivers who are going to be receiving it? What does the diagnostic process look like during a patient evaluation with an evolving form of recommendations?
Having a living document, rather than waiting a few years to publish a new edition, as we have in the past, I think could really be a game changer for psychiatric diagnoses. I think ultimately the goal is personalized medicine, that every patient is receiving those targeted therapies and treatments based upon their individual diagnosis. For example, if you and I both had depression, your depression wouldn't look like my depression based on our gender, our cultures, our backgrounds, our families, our support systems. And so I think having a document that is better taking that into account will ultimately really alter the diagnostic process, particularly if we're still being impacted by things like the 15-minute med check and all of the boundaries that our current healthcare system kind of places on psychiatry.
There's a clear correlation between the revisions to the DSM over the years and expanded diagnostic categories and criteria in psychiatry. Is it fair to ask if there's a pressure to narrow our definitions of diagnoses rather than continue to broaden them? Or I think it's more so the latter, that we want to continue to expand these to the full spectrum it addresses.
Psychiatry is a younger field and the brain is complicated. It's being honed and expanded as our understanding evolves. I think there's this concept of specificity versus sensitivity. So we can try and capture as many people in a diagnosis as we can. But psychiatry has also been accused of overdiagnosing. That's definitely something we want to avoid. I know ADHD in particular has become a target for criticism, that there are so many people now with ADHD. But as I mentioned earlier, our ADHD experts are telling us, yes, but our understanding of ADHD has evolved. Now we know there are more girls that have it. There are more adults that have it. I know we've covered this in past cover stories on adult ADHD. Our understanding has changed, and therefore the number of people who are carrying an ADHD diagnosis or have that as part of their identity, it's going to increase. I think that they definitely want more clarity on the definitions of diagnoses, but I don't know if it's a fear of broadening them. They just want to ensure that as many patients are getting the help that they need.
You mentioned it earlier, and I'm glad we get to return to it. The latest Psychiatric Times cover story regarding diagnostic changes penned by Dr. Aftab. He wrote about the current DSM doing little to contextualize the validity and the criteria of different diagnoses, which practices, I would note, are standard, again, among the other specialties, recommendations, and guidelines that are available. How is this issue affecting our shortcomings in clinical and pharmaceutical development?
As Dr. Aftab shared in our cover story, two patients might have functional impairments, but drastically different quality of life ratings, depending on their values, their expectations, their life circumstances. So the new model is going to try and target 4 interconnected domains. That is contextual factors, biomarkers and biological factors, diagnoses, and transdiagnostic features. I think he does an excellent job of summing up the ways in which they want to change the DSM, these new additions, some of which are bringing things back from the past editions prior to DSM-5, but also shows the skepticism a lot of psychiatrists, I think, are feeling about, is this doing enough to address the problems and challenges psychiatrists and mental health clinicians are facing? I don't know if it's able to fully encapsulate all of the things psychiatry is facing. One issue I know he's really interested in is dimension. Like, rather than making a binary diagnosis, how can we really understand a spectrum of psychiatric disorders? And I think that may be something that they do try and address. We will have to stay tuned.
Dr. Miller, again, in your interview with him, talked a bit about the proposed reintroduction of the contextual factors domain, as you're alluding to in the latest DSM updates. And what does he really see as the specific feature providing his colleagues? What exactly would that provide further from Dr. Miller's perspective?
Yes. So the new proposed framework evokes a multi-axial system that was previously used in DSM-4 and its update. These contextual factors span 5 domains: demographic factors, economic stability, neighborhood and built environment, environmental events, and sociocultural context. These psychosocial factors were removed from DSM-5 and kind of treated as supplementary, which was very controversial. Got a lot of criticism. But then not a lot changed between DSM-5 and then DSM-5-TR, its update. So now adding this back in is a big worthwhile change. We're returning to our roots of psychiatry, if you will.
For those of you who are younger and may not remember DSM-4 and DSM-4-TR, The five axes included axis one, which was their primary psychiatric diagnosis, so say schizophrenia. Axis two would have been a co-occurring personality disorder or personality traits or intellectual functioning. So this could include things like borderline personality traits or an intellectual disability. The axis three was any comorbid medical condition. So say, for example, a person had hyperthyroidism that was co-occurring or cardiovascular disease. And axis four defined any psychosocial stressors that could be contributing to their primary diagnosis. Axis five, I liked tremendously. It was called the GAF, Global Assessment of Functioning, where we would rate their current assessment, 0 being horrible functioning and 100 being perfect functioning. And basically, it was a number in that range that reflected their current functioning today when they presented and you assess them. And then we would give their global assessment of functioning, or GAF, as to how or what their maximal functioning was in the past 12 months.
So we kind of skipped it at the beginning when we're talking about it. What exactly does the timeline look like for this new iteration or the 6th edition of DSM? Obviously, once they get past the distinction of what it'll be called, what are we looking at for rollout?
So Dr. Wills, the chief executive officer and medical director of the APA, she says the committee is firing on all 8 cylinders, quote unquote. So I imagine we'll be hearing more on its rollout soon. But this is a complicated process. We want them to be thorough. We don't want them to treat this as a band-aid solution. So huge kudos to the APA and these subcommittees for addressing this problem with care and thought, for stepping up to the plate when criticism has come to the forefront. No one has set a concrete deadline, nor do I think they should. Taking the time they need to come up with a better end product will ultimately be worth the wait, both for our clinicians and for their patients.
And again, we're talking about a living document whose predecessors went through plenty of updates themselves. What areas of psychiatric research do we think are first going to influence the DSM updates when we get them through this living document down the road?
While I can't say what areas will end up influencing the newest edition, I can say that this DSM will be better equipped to advise clinicians as we learn more. I know, for example, there are a lot of biomarkers being studied in the Alzheimer's space. I know I mentioned ADHD diagnosis is developing, as our understanding does, as is schizophrenia. I think those major cornerstone disorders will really be the North Stars for the directions we continue to go for this DSM.
It may also be something as well that, something we again see in other conditions where there are few and far between treatment options, where I call it sort of like the chicken or the egg corollary, where it's a matter of fact seeing the benefit of a therapy, for a patient population that helps helps us better interpret the pathophysiology of the disease itself and its mechanism and its manifestations, and helps paint a clearer picture of like, oh, patients were benefiting from that, therefore we can derive better about this with the diagnosis. I am sort of interested to see, because we've had a number of interesting, agents and drug classes and drugs in circulation and discussion in psychiatry, certainly in the last decade. I'm curious to see if that's something that also helps inform it in the very near future.
Yeah, we'll have to see. I'm intrigued. As we said earlier, the DSM dictates what disorders are and what patients can receive what drugs, but does that effect go backwards? What drugs are available? What disease states are they impacting? What effect on patients are they having? Therefore, how can we classify these disorders? I think it'll be an interesting dialogue back and forth.
Yeah, absolutely. And as we're describing through here, a lot of measured criticism from our experts and largely the field that, the thought leaders that inform the psychiatric care field about the shortcomings of the DSM-5. If we were to take a temperature check right now on psychiatry, receiving this news of, yes, you're getting a living, breathing, evolving document of informed and refined diagnostics in the very near future, and we're hearing all your complaints, is there a warm reception? Is there excitement, or is there still a little bit of apprehension of like, yeah, we'll see?
I think there's definitely skepticism as to what the final product will look like. Is the APA addressing enough, or is this a desperate attempt to stay relevant? If they do this and they do it well, I think it'll be a huge kick at anti-psychiatry and anyone who's doubted them in the past. And I've seen so many of those conflicting views on both sides of the spectrum, both very positive and very skeptical. And that's what we do at Psychiatric Times. We're so proud to be the voice of psychiatry, where we can platform all of those voices, questioning or otherwise. Some people I think are excited about the new idea. They're hopeful that this will be better. It will address the other criticisms the DSM has faced. Others, they're not so sure. And I guess we'll really just have to see what the future DSM committee comes up with.
I suppose you could just credit the fact that, it keeps them light of feet, acknowledging that we're going to have to we know we're going to have a few more rounds of this always and forever. So we're just getting gamed for that now with a foundational document that addresses that. And as we're describing here, it really feels like there's sort of a dichotomous approach and takeaway we could take from, again, we're digesting a headline. We're not really working with anything constructive just yet, but obviously we have some nuances, perspective on where it's going. But when we zoom out from all the various factors being laid out, do we say that the new DSM is about redefining psychiatric diagnoses, or is it really about modernizing the field's diagnostic framework?
This changes a way to support and categorize what's happening in the brain. It's about finding a pathway for the best treatment. That's what we want. How do we get the best care for patients? Let's put a label on it. Without easy ways of determining what's going on, you can't take a single test and be like, yes, you have schizophrenia. Yes, you have depression. We need a lot of questions and ways to understand the patient's unique experience. And it's providing a much needed update to the standards by which our psychiatrists and mental health clinicians practice.
Excellent. Very excited to see what comes out of this. As you're alluding to, there's plenty more conversation that it will prompt. We're hoping that it, informs some more refined questions that get us to finer and finer points that help a greater swath of patients affected and, makes the lives easier for our clinicians. But I can't imagine it's going to be a perfectly smooth road getting there. So as you said as well before, everyone should be staying tuned to Psychiatric Times coverage of everything that's coming out with it. And just appreciate you sharing your insights with us today, Leah.
Thank you so much for having me, Kevin.
That is going to be all that we cover regarding the new updates to the DSM today. You can follow Leah on LinkedIn, and you can read her byline on psychiatrictimes.com, where you can also check out all the latest updates and coverage we have around psychiatric diagnoses and the upcoming DSM-6, or whatever they're going to be calling it in the near future. Check out the show description for links and resources that were all referenced today in our conversation, including Dr. Miller's perspectives on the new DSM changes. If you're interested in more news and insights on psychopharmacology, you should check out our show Brain Trust on psychiatrictimes.com, hosted by Dr. Joseph F. Goldberg. For The Health Beat, I'm your host, Kevin Kunzmann. Thanks for listening.